Welcome to the ILD Community Network podcast, where we bring together multidisciplinary experts to advance care for patients living with interstitial lung disease. Today's episode is being cross-posted on Rapcast and APAP Podcast, the official podcast of Rheumatology Advanced Practice Providers and the Association of Pulmonary Advanced Practice Providers. I'm Amanda Mixon, President of Rheumatology Advanced Practice Providers and your host for today's discussion. In this episode, we'll focus on one of the most impactful and often under-recognized complications of interstitial lung disease, pulmonary hypertension associated with ILD. Too often, PH-ILD develops quietly, masquerading as ILD progression, leading to delayed diagnosis and missed opportunities to intervene earlier in the disease course. To help unpack where these gaps occur and how we can close them, I'm joined by Corinne Young, President of the Association of Pulmonary Advanced Practice Providers. Corinne brings deep expertise in pulmonary care and a strong perspective on real-world challenges clinicians face when identifying PH-ILD in everyday practice. Together, we'll explore the clinical signals that are commonly overlooked, discuss when providers should escalate evaluation beyond ILD progression alone, and highlight practice strategies for improving early recognition through multidisciplinary collaboration. So let's go ahead and get started. Welcome, Corinne.
Thank you so much. These are my two favorite topics, pulmonary hypertension and interstitial lung disease. And so to have them together, I'm very excited to be here and talking to you about it.
Oh, I know that you're going to teach me a lot like you always do. All right, we'll go ahead and get started. From your perspective, why is PH-ILD so commonly under-recognized in patients with established interstitial lung disease?
That's a really good question. The main reason I believe is that, in earlier stages of pulmonary hypertension, before we have just fulminant right heart failure, all the symptoms of pulmonary hypertension associated interstitial lung disease, they have the same symptoms: shortness of breath, activity intolerance, fatigue, right? So we anticipate those symptoms with our ILD patients anyway. So if they already have interstitial lung disease and they're complaining of, some breathlessness and, not able to do the activities that they were once doing, we may not recognize it as being a secondary disease, that it's may just be their interstitial lung disease progressing. And as you know, in rheumatology, a lot of these patients who have SARD, the systemic autoimmune rheumatic disease of the lungs, when they have autoimmune related lung disease, they can have flares. They can have worsening symptoms related to the underlying driver of their rheumatological condition. So sometimes we're thinking that first, and we're not necessarily thinking that it's pulmonary hypertension. I think a lot of times, unfortunately, the PH-ILD patients aren't really recognized until they start having heart failure symptoms, edema, frothy sputum, things that just aren't very typical that we would see in interstitial lung disease. So lower oxygen levels are also an indicator that they have PH-ILD. But again, we anticipate our patients have lower oxygen levels with ILD. And as it progresses, that's something we commonly see. So unfortunately, it just kind of sneaks under the radar with all very similar ILD symptoms.
Super interesting. So from like a rheumatology perspective, you kind of discussed this already, but what are those kind of key signs, symptoms that should really raise our concern that maybe this person's developing pulmonary hypertension? You mentioned edema, lower oxygenation. Are those the big ones? Are there anything else that we should be thinking about?
If you happen to be looking at their imaging, their lung function testing, sometimes a good cue that you should go looking for pulmonary hypertension if you haven't already may be that their overall imaging doesn't look significantly worse. We don't see new areas of disease developing. Radiologist, if you're not looking at your CAT scans, if the radiologist is saying stable interstitial findings or interstitial lung disease or stable reticulations, but your patient's just having a lot more breathlessness, that would be a good red flag to recognize and get an echo to see if it's anything else. I commonly tell my children this and everybody else I work with that life is not fair. And so it's not always just one disease causing all of their problems. They could have all sorts of things. They could have coronary artery disease. They could have all sorts of things impacting their breathlessness. As you know, it's just a very vague symptom sometimes that could mean everything or nothing. Another one would be, again, if you're looking at their lung function testing, we trend FVC, the forced vital capacity on patients with interstitial lung disease. We also look at their total lung capacity. And the last thing that we look at is their diffusion capacity, how well gas is exchanging in the cardiopulmonary space for these patients. And so we know interstitial lung disease causes decline in FVC, decline in their total lung capacity because they lose that compliance of their lungs. And the gas exchange gets impacted because the parenchyma, the tissue that holds everything together around the air sacs, starts to thicken up and fibrose, and gas can't diffuse through very well. Well, another thing that can affect your diffusion is the circulation on the other side that's exchanging gas and carbon dioxide. So if we have bad circulation issues because the pulmonary arteries are affected, then we're going to end up with a worsening diffusion. So sometimes what we might see is that the diffusion capacity is disproportionately low to what everything else looks like clinically for that patient. Or that might be the only thing that worsened in your patient. So their CAT scan's stable, their FVC, their TLC is stable, but their diffusion dropped 20%. That is a red flag that like something's happening, in that space. So we would definitely want to evaluate with an ultrasound, echo, cardiogram of the heart, so that we can kind of see what's going on there. Of course, frank heart failure symptoms, edema, these patients unfortunately can kind of have this low burden of disease on the right ventricle from increased pulmonary artery pressures. And then, they have an event, they get flu, they get COVID, they have something that happens, they go into acute respiratory failure that stresses the right heart out, and they develop right heart failure symptoms, which look exactly like left heart failure symptoms. So you don't have to worry about telling those two apart, but just looks like heart failure. These patients are very compromised at that point, and I think is very easy to understand. Last thing I would say that might be a trigger for you to start looking for pulmonary hypertension is if you're getting imaging because you're waiting for them to get into pulmonology and you're being a good steward, in rheumatology of your ILD patients who have an autoimmune interstitial lung disease, and you're getting a CAT scan, a high resolution CAT scan, by the way. And the radiologist happens to mention that the pulmonary arteries are enlarged. That's a good indicator that they likely have some pulmonary hypertension, and we need to have an echo.
So let's talk a little bit more about echoes. I mean, sometimes I struggle with this. Like all of my scleroderma patients, right? Like I order an echo as a baseline, and I typically will do it, I don't know, every couple of years. I guess it depends on the patient. But I know this is the screening tool, but what are the limitations in ILD patients, and how should clinicians interpret borderline or inconclusive findings? I mean, because the other thing that sometimes I see is the classic unable to determine, pulmonary pressures, and then I don't know what to do. So, can you speak to that a little bit?
Yeah, absolutely. There's a lot of indirect measurements of pulmonary hypertension on an echo that may give you an idea that there could be some elevated pressures. I love rules. I love black and white. I love clarity. If I knew how gray medicine was, I probably wouldn't have gone into it. But echoes are a pretty gray tool, and we hang our hat hard on that tool when we are looking for pulmonary hypertension in patients. It is the number one and really only screening tool. There are other things that we do to look for pulmonary hypertension, but they are more invasive and can be costly. So echoes are a great screening tool because they're cheap. It's an ultrasound. It's warm jelly on your chest sometime out of your day and your copay, but it's not a terribly invasive exam. So, unfortunately, echoes are known to overestimate the pulmonary artery pressures and underestimate them. I had a patient who her right ventricular systolic pressure was reading 90. It should be under 35. And so we thought, oh, she's got pulmonary hypertension. The confirmatory test is a right heart cath that we do in the hospital, but they go home the same day. We do it in the cath lab. Her pulmonary pressures were totally normal in the cath lab. So this was an overestimation. Vice versa, I had patients who their pulmonary artery pressures were just mildly elevated, maybe 40 on echo, And in the cath lab, they were reading, over 60. And so, you kind of have to take an echo with a grain of salt. It's always lovely when we get some sort of number, but unfortunately, just to make you feel more insecure, you can't really even depend on that number. So I would say the few things that I would look at on an echo report to give you an idea is, could there be some pulmonary hypertension outside of the RVSP, the right ventricular systolic pressure, or you may see PASP, pulmonary artery systolic pressure, um, would be to look at the right ventricle, the right side of the heart, basically, the right ventricle and the right atrium. They shouldn't be enlarged. And if they are, that's telling you it's a downstream of, backing up of effect of the pulmonary artery pressures being high. The right ventricle is a thin muscle. It only has to push from the heart to the lungs. It's not a very far distance versus the left ventricle is a very thick muscle because it has to pump from your nose to your toes, right? So it's a stronger muscle. Well, the problem with the right ventricle being a thinner muscle is that when pressure backs up, it's very easy to stretch it. Well, if you're trying to squeeze a ball with your hand already, partway clamped versus having your hand wide spread open and you try to come back and squeeze, it's a lot harder to do. And so the right ventricle has difficulty squeezing when it is dilated. So any dilation or evidence of enlargement is what the cardiologist may report. Enlargement of the right ventricle, right atrium, that's telling you that there's a back pressure here that needs to be evaluated further. And, send them to us, send them to cardiology, send them wherever you can get them in. But they definitely should be evaluated. So another indicator on the echo would be TAPSE, and it's T as in Tom, A as in Apple, P as in Paul, S as in Sam, E as in Edward. It stands for tricuspid annular plane systolic excursion. It's a calculation. It's not something you can really measure yourself. They have to measure it during the echo. And they calculate basically the longitudinal displacement of the lateral tricuspid annulus when they're doing a special what's called M mode on the ultrasound. And basically, you want your TAPSE measurement to be like 1.7 or 1.7 centimeters or 17 millimeters or higher. A high TAPSE is good. A low TAPSE would be 16 millimeters or 1.6 centimeters. The lower it is, it basically translates to poorer right ventricular function. And so again, when the right ventricle is not functioning, it's usually because of the pulmonary arteries. And so that would warrant some more aggressive evaluation. Now, again, because life's not fair, I would probably say in my community, with the echoes that I get back, I would say probably 60% of them will give me a TAPSE reading. And sometimes it's buried in it's not in the summary of the echo. So you may have to scroll down to the tricuspid valve discussion, and they will sometimes give you a TAPSE in the tricuspid valve discussion area. But sometimes it's not there either. So then you don't have an RVSP, you don't have a TAPSE, and you're just kind of stuck with like, well, what does the right ventricle look like? And is it enlarged? Is the CAT scan telling me the pulmonary arteries enlarged? These kind of pieces of the puzzle are telling me there might be some pulmonary hypertension. The last thing I would say is if you're going to go down and look at the tricuspid valve, section, trying to find a TAPSE level of 1.7 or higher, sometimes if there is severe tricuspid regurg or failure of the tricuspid valve, it's often because there's just so much pressure, it can't close very well. And so again, that would be from pulmonary hypertension more than likely. So I would say, look at the RV or the right side of the heart, the right ventricle and the right atrium. Look at the TAPSE if you got it. Look at the pulmonary artery pressures if you can get them. And then you look at the tricuspid valve. Those things should tell you this is, likely a patient who has some overlapping pulmonary hypertension.
Wow. Didn't know any of that. I've always just looked at that little number and then, if it's below the 30 or whatever, like, okay, great, the patient's all set. And
Yeah.
so this is super helpful. And I wonder if, even when we're writing orders, because oftentimes, we're the ones diagnosing them with scleroderma or whatever it might be. And if we can just ask the person that's doing the echo to do that for us, I'm sure they know how
Yeah.
to do that. And so it maybe just be something to add to the order so that we can try to put the pieces together.
When I have patients coming to me from like remote areas, which we're both in Colorado, there's a lot of patients in small mountain towns. They have these very small hospitals that they go to for their imaging. Um, and oftentimes when I order an echo, I will write comments if there's an area for me to write comments to the ultrasound tech or whoever echo tech that it's going to that please rule out pulmonary hypertension. Please look for something that they know I'm that's specifically what I'm looking for. Pulmonary hypertension in general is a little bit of a redheaded stepchild. Everybody's so concerned about the left ventricular function, the EF, right? They're concerned about those things and the valves in general. Oftentimes the right heart doesn't get as much attention because, and if the cardiologist doesn't know what you're looking for, also when they read the echo, they may just not give you very much information and you want them to give you everything. And I've noticed when I put that comment, the cardiologist does say, not only gives me a lot more information than I might have gotten without it about the right side of the heart, but will outright say no evidence of pulmonary hypertension because they know that's what I was looking for. And so then I feel a little more comfortable that they don't feel there's pulmonary hypertension there either. Could it still be there? Unfortunately, yes, but it's less likely and it's not as likely severe or, anything like that.
Well, on that same note, I mean, how do you feel like we can better align on when we should be involving a pulmonary hypertension specialist or kind of pursue that right heart cath?
hmm So the we love when our rheumatology compadres get a baseline of an echo, lung function, chest imaging. It's so helpful when patients come to us before they really develop disease. Sometimes in that screening process, you find disease, right, that you didn't anticipate to find. But other times you are creating this baseline because, again, life's not fair and patients smoked in their past, right? So we may also have overlapping COPD. We may have other overlapping conditions that may muddy the waters when they're breathless. And we need to know, is their COPD worsening, which looks very different on a lung function test than if their ILD is worsening. So, having that baseline, I would say, is just so great to get a baseline image, high resolution CT, full pulmonary function test. And if you really want to go the extra mile, an echo, because as you know, rheumatological disorders can also cause PAH, pulmonary arterial hypertension. They can damage the pulmonary arteries, remodel them, and they develop, this pulmonary vascular disease. And then with pulmonary hypertension, associated with interstitial lung disease, this is considered a group 3 disease. And so all of them need a right heart cath to confirm that there truly is pulmonary hypertension there. And that really would be left up to the team that's going to manage the pulmonary hypertension. There are cardiologists that are very interested in pulmonary hypertension outside of PAH. So it gets confusing. There's 5 different pulmonary hypertension groups. Group 1 being PAH, and there's multiple things within that group 1, like methamphetamine use and autoimmune disorders and hereditary and idiopathic. Um, and then and a lot of cardiologists really do specialize in pulmonary arterial hypertension. A lot of pulmonologists will also concomitantly treat those. And then we have groups 2, 3, 4, and 5, which are considered pulmonary hypertension. And we used to call it back in the day secondary pulmonary hypertension, which makes sense. They have pulmonary hypertension secondary to something else. In group 2, it's secondary to heart problems. They've got bad valves, they've got left heart disease, heart failure, or whatever it might be, left heart failure. Group 3 being sleep apnea that's untreated. Their pulmonary hypertension is secondary to the interstitial lung disease. It's secondary to their COPD or whatever it might be. 4 is secondary to a clot in the pulmonary artery. 5 is some metabolic disorders and some other congenital heart disease and things. So, groups 2, 3, 4, and 5 oftentimes are usually managed by a pulmonologist. And so what we're talking about today with pulmonary hypertension associated interstitial lung disease, that's generally going to get referred to the pulmonologist. even if their ILD is very mild, they're not symptomatic for it, but you start seeing evidence of pulmonary hypertension associated. Personally, I would start the pulmonologist because we're going to manage both, the interstitial lung disease, pulmonary hypertension, and there are now group 3 drugs. And so we're usually, again, going to be the ones to manage that, or a pulmonary hypertension center if you have access to that. And they're usually going to be at tertiary care centers. They're going to be at universities. They're going to be at big, big institutions that manage a lot of pulmonary hypertension and PAH as well.
Wow, that is so interesting. I actually didn't know that there were 5. I always learn so much from you, so I really, really appreciate this, and I know that our RAP listeners will feel the same, and that kinda leads me to my next question. So what role do comorbid connective tissue diseases play in both the risk of PH-ILD and the urgency, perhaps, of earlier screening?
So they do carry a higher risk. We know that even again, without interstitial lung disease, we know a lot of these connective tissue disorders can affect the vascular bed, the pulmonary arteries themselves, and can cause group 1, could PAH, right? And then we know that they can also cause interstitial lung disease, damage the parenchyma, damage, the lungs in a way to cause fibrosis and scarring. On pulmonary hypertension associated interstitial lung disease, the two together unfortunately carry such a high mortality, higher than the diseases individually, which makes sense. 1 plus 2, it's worse to have both of these diseases together. And these patients, unfortunately, have a lot of symptoms. They're very poorly controlled. Their diseases tend to go very quickly. And so we do want to identify them as fast as possible. So that's why that screening, with the echo, the lung function, and the CAT scan are great, because you may catch something really early and we can initiate therapies very early in these patients. Selfishly, on my end, I'd always want their autoimmune disorder to be as controlled as possible. So I'm always like, is there anything else you could do? Is there anything else that we could do? I don't care if they don't have an immune system. Suppress it all you want. We just want to get the driver of it under control. So that's something we really heavily lean on our rheumatology partners, for. And then on our end, we're going to try to manage the other two. But unfortunately, the two diseases together do have very bad outcomes for these patients, and can feed each other as well. Because the worse the interstitial lung disease gets, it backs up more pressure to the pulmonary arteries, and if the autoimmune disorder is already causing some damage remodeling of the right ventricle and everything else, we're going to just have more progression of disease.
We feel the same way. It's kind of like you really need to try to control the disease process so that hopefully this person doesn't get some of those other manifestations, but then if they do, we really have to be more aggressive, because again, it's so systemic. And so I appreciate that. And also just when in doubt, call your pulmonologist, your pulmonology provider that you can reach out to.
Yes.
So this is kind of a loaded question, but in your experience, what system level barriers like time, access, workflow most often delay PH-ILD recognition, and how can teams realistically overcome this?
I think that one of the barriers is access for patients and getting screened, right? And I'm sure you even see this with their underlying, connective tissue disorder. They've been living with it for a while. They're thinking they're just old. It's just osteoarthritis, or it's just a dry mouth, and, or whatever it might be. They're not really associating it with whatever the underlying disease process is. So oftentimes we inherit them after they have been in this disease state for longer than we would like them to be untreated, right? And so I think that's part of it. I think there are still maybe some older rheumatologists that we don't tend to get screening exams of the echo, high-res CT, and the lung function until they're symptomatic. So sometimes that seems to be a trigger for rheumatology to do those exams, is they wait until they're symptomatic. Well, if they're symptomatic, they have the disease, right? So, at that point, we're just kind of playing fireman. So we want to screen as much as possible. So on the patient side, they may live with the disease longer than we would like them to before it's recognized, either by their primary care. They may be going and complaining to their primary or urgent cares or wherever, and they're kind of being, pushed aside because they're overweight and have a smoking history. And so like, yeah, you're breathless because of that, right? They're not doing high resolution imaging because early in interstitial lung disease and early in pulmonary hypertension, your x-ray is normal, you know? And so they're not really often getting that deeper dive of evaluation. So there's a little gatekeeping there with who they're accessing and when they're accessing. And then I think also on our end, and I will say pulmonologists are just as guilty. We see the interstitial lung disease, we get all excited, we start going after this interstitial lung disease, and we don't think to do the echo. And right now, there's not really any great international standards of when to screen for pulmonary hypertension and interstitial lung disease. So we don't really have any guidance there. I think, as a organization, you and me talking about this, we're just trying to make the point of, all these patients should have these screening exams, a baseline exam at some point, just so that we can catch it earlier. Because if you're not looking for it, you're not going to find it. And then when you do find it, it's usually because it's too late.
And I think too, like that's why this is so important. Doing these, doing the ILD Community Network. I mean, it's really connecting rheumatology with pulmonology, with primary care, so that you also know who your resources are in your community. That way, if you do suspect one of these things, you can get that patient in sooner rather than later. Time is tissue. And so we really have to be thinking about this and getting on top of it.
Yes. I'm so glad you've done this because in our local community, although we're both in Colorado, we're hours apart from each other. But through the ILD Community Network, I met an ADP who's at a rheumatology clinic that's like maybe an hour from my clinic. And locally, I have about a 6 to 9 month wait for patients to get into rheumatology. They do triage them, so certain things they might get in a little bit sooner. But if I got an interstitial lung disease and they're seropositive for something that I'm like, oh, maybe we need somebody else to look at this and say, is this truly a systemic disease or not, or what's going on? They won't see those patients any faster because they have interstitial lung disease, in my area. And I don't know how it is in everybody else's, but there's not enough of you guys, not enough rheumatologists, not enough rheumatology APPs. But I found out that this APP in this clinic was like, if they're willing to drive, I will see them, a lot faster if you send me the referral. And she's getting them in like 4 weeks. And so patients are willing to do that a lot of the times when they're very worried about the rheumatological or they're suffering with symptoms. And I could say, are you willing to drive an hour? Because there is a clinic that I can get you into. So I would not made that connection with her. I would never, known her or that she'd be willing to do that for our patients. And it's great. And vice versa. So she's now sending patients to me that she notices are, she's worried they may be developing lung disease. And so, we're kind of making room for each other's patients, which I wouldn't have had that connection without, the network.
Oh, that just warms my heart. That's what this is all about.
Yeah.
So one last question for you. If you can leave our listeners with one practical takeaway to improve earlier recognition of PH-ILD in their own practice, what would it be?
I would say always dig a little deeper. There's lots of reasons for patients to be breathless. Especially where we live in Colorado, we're high elevation. Unfortunately, the population's overweight. Not everybody's in great shape. And they may have an underlying left heart disease, right? They may have AFib, or they may have left heart failure or HFpEF or HFrEF or something else going on, a leaky valve. I would just say, just dig a little deeper and make sure it's not anything else. Because I've had, unfortunately, a lot of patients who had great reasons to be breathless and did not get further imaging or ultrasound. And then that turned out that was the problem. And they had just been told that they need to lose weight, they need to get active and, whatever it might be, but it wasn't getting better. They weren't getting better. And so definitely get that ultrasound, high resolution CT scan, not a plain CT, high resolution, lung function. If you can get those 3, you're going to have a really good idea if there's any overlapping lung disease related.
Well, and to your point, doing these things at baseline, like not waiting for the person to be symptomatic because they might have early changes, and everything caught earlier is obviously much more treatable. So I couldn't agree more. And then now just even understanding how to interpret the echo, I think is really, really going to be key for our listeners. That brings us to the end of today's conversation on recognizing pulmonary hypertension associated with interstitial lung disease and the critical steps we take to reduce diagnostic delays and improve patient outcomes. Discussions like this underscore why multidisciplinary collaboration is essential in ILD care. The ILD Community Network was created to bring pulmonology and rheumatology together along with primary care, helping to break down that siloed care and support more coordinated, patient-centered approaches to complex diseases like PH-ILD. To learn more about the ILD Community Network and access additional resources, visit www.ildcommunitynetwork.org. Thank you for listening to this episode. We appreciate you joining us, and we look forward to continuing these important conversations aimed at improving care for patients living with interstitial lung disease.